Right. Welcome, everyone. This is our session 3 of our Quality Cafe. I have a feeling that this experiment is going well from the number of attendees showing up today. So thank you everyone for coming. If you're able to change your name, rename yourself with your facility name, it helps us to know where people are coming from. That would be awesome. So today we're going to be talking about falls prevention with a focus on reducing falls with injury. Our plan is for me to present I have some statistics for hospitals and nursing homes, and we'll have some time for facilities to share. And then I'm very pleased to announce that Pat Quigley is with us to also share some falls prevention strategies. I think she's going to speak a little bit about behavioral health. That, and then we should have plenty of time for Q&A and discussion after the presentation. So probably only do about 30 minutes of content like we have. All right, so we will get started. And this is being recorded, so you can get a copy of it with the resources afterwards. I just pulled some data from Sentinel events from the Joint Commission. The reports are linked, will be linked in the document, but there were 1,441 Sentinel events in 2022, which was a 19% increase compared to the year before. A majority of those Sentinel events were voluntarily reported by the facilities, which is a good thing. I did also put in the Joint Commission Sentinel event alert. It's an old one on falls, but it's got a lot of good info. So if you haven't seen that, you can link there. This is just the distribution of Sentinel events by year, and you can see the number of Sentinel events have gone way up in the last couple of years. This is the top types of Sentinel events, and if you look down at 2018, falls were 16% of them, and then in 19 it went to 18, 21, 40, and 42. This was just very striking to me. It's like they've figured out the other things, but falls they haven't quite got that one dialed in yet. So for Sentinel event, just so everyone's aware, a fall has to have harm, either permanent or temporary, and deaths are all included as a Sentinel event for a fall. So these are injury falls. So these are the straight numbers by year. So 611 of them in 2022. The leading injuries were head injuries and hip and leg fractures. And patient falls with ambulating was the leading mechanism of falling, followed by falling from bed and falling from toileting. The reported contributors to those falls include policies not being followed, like the falls risk assessments not being completed per policy, inadequate staff-to-staff communication during handoffs, and lack of shared understanding of the plan of care. Just popped in the Joint Commission standards that relate to falls, just so you'd have them for your reference. Don't need to read them. So this data is a little bit older. It's from 2019, but epidemiologic studies found that falls occur at a rate of 3 to 5 per 1,000 days. That's just a lot. So I was just curious if you guys want to put in the chat, what units do falls occur at your facility? So specifically to hospitals right now. I always think med surg because that was my background, but what other units are falls common in your facility? If you come off mute, pop it in the chat. It could be a little interactive today. Everyone's being quiet. Other than med surg, it's like already behavioral health, inpatient rehab unit, ER, med surg, and mental health. Do we have many falls in like OB? Probably not necessarily ICU. Those people are fairly sick. All right. I was able to pull the data from our telegen reporting facilities. These are falls with injuries through the, and these came from claims. The green line is Alaska hospitals, and this is the falls rate. So we're definitely below the 3 to 5 that was in that 2019 study. The orange dot is all of the Telegen hospitals in the HQIC that are reporting. So other than a couple blips, at least our falls rate by claims is pretty low. I wanted to spend a couple minutes talking about long-term care. So I put the MDS definition in here. MDS defines a fall as any unintentional coming to rest on the floor, ground, or any lower level. So even a chair counts. And then one thing that I always questioned, but this is what the MDS says, is even if the resident was caught or assisted by staff, it's still considered a fall. So an episode where a resident lost her balance and would have fallen if not for staff intervention still counts as a fall. The CMS regs for nursing homes say that nursing home facilities must ensure the environment is free from hazards, that each resident has adequate supervision to prevent accidents. CMS reports that muscle weakness, gait problems are the most common causes of falls among our elderly residents and account for about a quarter of those falls. I was able to pull the Alaska citation history for FTAG 689, and that's the free of accidents survey tag. So let's see, out of 20 nursing home providers in Alaska in 2020, 25% of them were cited for F689. So that may not all be falls. I didn't dig into it deeper, but basically 25% in 2020 had that citation. And we were a little bit higher in 21 at 30%, but kind of holding steady at 20%. The 2023, it looks like the last upload into that was in August. So we don't have the last bit of the year. So that number may rise a little bit. I got this language directly from the State Operations Manual for Long-Term Care, and they outline what they want to see for proper actions following a fall. So, obviously making sure the resident's okay, determining what might have caused or contributed to the fall, addressing the factors for the fall, and the care plan must be updated to reflect that. And then in there, they definitely state that a fall by a resident does not necessarily indicate a deficient practice, because not every fall can be avoided. But as we know, the less falls we have, the less likely we're having to have falls with injury. While I was researching, I found this really cool toolkit by the AHRQ. It's a little bit older, it's from 2017, and I did put the links in here for people to use, but it was using your EMR to help you determine who's at risk for fall and where your problem areas might be. So it was, can you build this report in your EMR using MDS data and data from your MAR and some assessments? And I thought it was really innovative and something to do. I don't know if anyone's using something like this at their facility. But then the next step was they took the actual falls they had and compared that information to see what they had. So I put the links to those in the chat, in the slide for you to have. I am going to put a little plug in here, is that so AHHA has partnered with the Proactive group. We're doing a series for the year on documentation for long-term care, and the January training is going to be documentation related to falls and accidents. So the link to register will be in the slides for you for that. With that, I wanted to talk, see if Lorraine, are you on from Sitka? If she wanted to talk a little bit about some of the technology they're thinking about. I'm not sure if they've implemented it yet, but I have just a little info I put up on a slide for you. But I'll give you the floor, Lorraine, if you want to chat.
Yeah, hi, this is Lorraine from Sitka Long-Term Care. And back in 2018, we did have a Sentinel event. And we developed a chats program. We implemented it along with 15-minute rounding. The chats program is every 15 minutes, do a walk by, make sure the call light's within reach, check to make sure the resident has something to drink, hydration, awareness, bed positioning, resident positioning, the fall mats in place. If the resident's awake, offer toileting, and then of course as safety. 15-minute checks is something that any one of our staff, it doesn't have to be a nursing personnel, can do. And it's, like I say, just basically as you're walking in the hall, just glance over, make sure the resident is safe. Since implementing this, we have not had a major injury. And it's been extremely successful. The entire staff's able to implement the chats program, and it's been a win-win for us.
That's awesome. Does anyone else have any falls updates that they want to talk about, or what they're doing in their facilities? Just looking at the list to see who's on. Trying to put you on the spot, but not necessary. One second. Well, thanks, Lorraine, for giving us your update. That's awesome. I am now going to move on to handing the floor over to Pat quickly, because everyone's here to see her. So I think you said you didn't have any slides, so I think I'll just stop sharing so we can see your face. And I will
actually, could you go back onto your presentation? I'd like to see the Sentinel event. I couldn't quite see that one. Could you go back on that,
Sure.
Kristen?
Yep. I'm gonna figure out how to share my screen again.
Yeah, and while you're doing that, no worries, Kristen. But while you're doing that, I cannot tell you, colleagues, how excited I am to be with you. Happy holidays, number one. And number two, thank you. A shout out to Debbie for inviting me. I'm always just, always pinch myself when Debbie brings me home to Alaska. I've visited with so many of you, over the years, and I'm just thrilled to be able to be with you and talk about falls. And I was hoping to look at that, the Sentinel alert. Yeah, that's the one I'm looking for, because I wanted to see which Sentinel alert that was, Kristen. But Kristen, I want to say thank you for your leadership, and thank you for opening up this session on falls and fall injury prevention, because colleagues, this is such an important topic, because as you saw from the what Kristen presented to you is that, yeah, people are still falling in our care and they're getting injured. I mean, this is just year after year that the Joint Commission reports that falls with Sentinel alerts, that those are actually injurious falls. Okay, so the Sentinel alert actually that I was looking for was Sentinel Alert 55, which was published in 2015.
Yeah, that's the one.
I see that you have if that's the one that you have, but and that might be the Sentinel alert link that's right below that one. Yeah, so that might be the Sentinel alert 55, which I actually got to help right before I retired from the VA. But just a little bit about myself, colleagues. Yep, that's it. So let me just see if that's a little, I think it is September
28th.
Yeah, 55. Is it 55?
Yes, it is.
Yep. Okay, so that's what we wanted. So colleagues, I'm a nurse's nurse. I'm a rehab nurse, and my whole world is fall and fall injury prevention. And thank you so much for putting up that Sentinel alert. But my legacy is the Department of Veterans Affairs. I retired in 2016, and I have my own business since then. But I've spent a lot of time with you on visiting your hospitals and your long-term care facilities to know about the great work that you're doing in fall and fall injury prevention. And shout out to Lorraine, great job that you're doing. And I was so glad to hear that you put down floor mats, because when you're looking at fall and fall injury prevention, it's always really, really important to realize that fall prevention is separate and distinct from injury prevention. So that's why when Debbie asked me to present, I just wanted to have time to be able to chat with you, because after this session, you know, if you want to have a more in-depth session, Debbie, we can, and Kristen, we can always do that. But to be able to answer some questions that you have, but to give you some overview and some highlights first. So with the information that Kristen helped to launch that is foundational, that Sentinel Alert, which is now, it was 2015, it's 8 years old, colleagues. You know, it actually is the framework for all things that I present. And that Sentinel Alert 55, I think, is always worthy to be reviewed again by everyone time and time again. And there were 4 recommendations that I really highlight out of that Sentinel Alert. And the first recommendation in that Sentinel Alert is that all of us have a responsibility to create a safe environment. When people come into our care, whether it's a hospital, whether it's long-term care, you know, whether it's assisted living, all of us have a responsibility to make sure that our environment is safe. And when our environment is safe, then what we're doing is we're reducing accidental falls. In addition, and I'm just going to highlight 4 of the recommendations, Kristen, just so you know, but that is our job, is to create a safe environment. The next thing that we're supposed to do is to work people up for their actual fall risk factors. So that means when people come into your care, it doesn't matter if they're high fall risk. What actually matters is why they're at risk for falling. So that's why everybody should be using standard and validated tools that not homegrown tools, but using validated tools to be able to identify, sure, what someone's score might be, but the score doesn't tell you why they're at risk for falls. So you've got to get to my impaired vision, you got to get to my postural hypotension, you have to get to my sensory neuropathy, you have to get to my centrally acting medications. You have to know why I'm at risk for falls. And when you get to that kind of an assessment, colleagues, and that's not screening, asking yes or no, whether or not someone's at risk for falls, then, and you identify them, then you have to treat them. So that means you got to make sure I got my glasses on, you're going to treat my postural hypotension, you're going to look at my medications and see what you can change. So whenever you find risk factors and you treat them, then you're going after the anticipated physiological fall. And then the next thing that you have to do after you've worked people up preventing this, and you're trying to prevent 2 types of falls: accidental falls related to an unsafe environment, and protecting people from reducing their risk for the anticipated physiological falls, doing an individualized care plan, whether they're in long-term care or hospital assisted living. You've got to work people up for their fall risk factors. But the last recommendation is you have to know, colleagues, you have to know who is at risk for injury. So, you know, in long-term care, you have the MDS work. So when people come into long-term care, you know whether or not someone's had a hip fracture in the last year. But hospital staff don't always know that. So whenever you're trying to go after preventing falls and protecting people from injury when they fall, you have to know what are their history, what's their risk of injury, what's their history of having a risk for injury. So where am I taking you? You should know in your population who has osteoporosis. And you have a lot of people in Alaska that have deficiencies because of the loss of sunlight, and you got a lot of people who are osteoporotic. So you should know who's osteoporotic, and you can finish with that now, Kristen, that's okay, but thank you so much for putting that up. And then you should know who's anticoagulated. So those are your 2 leading risk factors for people having an injury if they fall in your care. And then the next thing you should know is what % of your patient population who is over the age of 85. And the reason why I'm saying that to you is because people over the age of 85, falls is their leading cause of unintentional injury death. So I'm taking you to the tip of the pyramid. Everybody's at risk for falls, but the question is, anyone can have a fall. I mean, we all fall. I fell in October again. I won't tell you why, but I know why I fell. It was accidental. But, you know, we all are at risk for falling. But then as you move up the pyramid to vulnerability and risk, you have patients who have more risk factors that make them at risk, not just for falling in having an accident in an environment, but physiological changes that happen as we grow and age gracefully each and every day. So those put us at risk for the anticipated physiological fall. But then you keep on going up that pyramid, and I'm hoping you can see my pyramid here. Now you're getting to people 75 and older, people at risk for injury if they fall. And in addition to that, you should know who has a history of an injury because of a fall. So fall prevention is separate and distinct from injury prevention. So you have to include in your admission assessment process who is at risk for injury and who has a history of a fall-related injury already. Because now you're going to get to the people who are known fallers and people at risk for injury, because protection from injury is separate and distinct from protection from a fall. So the point is that if someone does fall in your care, like Lorraine is doing, she's got floor mats down. So she's anticipating that people could fall getting up from their bed without you, and she's going to protect them from injury. So she was able to report to you reducing the falls, but we also want to be able to protect people from injury. So the admission assessment process is really critical. Is not only asking about fall history, but asking about injury history and injury risk. So everybody is asking about fall risk, fall history, but you should be asking about injury risk. So I just want to make sure that that's really highlighted. And the Sentinel alert is very much in alignment with those recommendations, realizing that everyone needs to have leadership on board. So what I want to say is, as you focus on your fall and fall injury prevention programs, you should be really targeting two types of falls that are preventable. One's related to your environment, and ones that are related to risk factors inherent to my person. So when someone does fall in your care, you want to be able to trend, and you have some of this data from Kristen, is why are people falling in your care? And that's part of why I'm here today, is to be able to talk with you about that. And that gets into the post-fall huddle, which is also in the Sentinel Alert 55. So, you know, when we know that there's a whole, even though you look at fall rates, we heard that on Kristen's presentation, 3 to 5 falls per 1,000 patient days. We know that there's a whole other side of the equation where patients are not falling in your care and they're not getting injured. But for those who do fall in your care and those who do get injured, you should absolutely know what was the cause of their injury. Why did the body go down? And when you know the immediate cause of the injury, then you've got to do something about it, which means you have to align the intervention to the reason why they fell. And that gets into the post-fall huddle. The post-fall huddle is probably one of the leading interventions that came out of the Patient Safety Center where I worked for years in the VA, that everybody should be doing, and everybody should be doing it the same way without modifying it or missing steps in it, because when you do that, you can't get to the outcome of knowing why someone fell so that you can prevent it from occurring again. So maybe you can put in the chat whether or not you have confidence that someone who falls a second time in your care did not fall because of the same reason as the prior fall. And so I'll just say that again. Maybe you can put in the chat, you know, and maybe Debbie and Kristen, you can monitor the chat to see what happens here, because Kristen's been asking you to put stuff into the chat too. Do you have confidence that someone who falls a second time did not fall again because of the same reason as the prior fall? And oftentimes when I ask that, I can tell you people do not. They don't have confidence. See, not always. We have one response already. So honestly, colleagues, that's the confidence in your post-fall huddle. It is our responsibility, if someone does fall in our care, to make sure they don't fall again because of the same reason. We cannot have someone continuing to fall because their blood pressure is dropping. We cannot have someone continue to fall because you're putting non-skid socks on a patient who can't feel their feet. You can't do that. So, you know, those are the things that we really want to work on. So that's the part of the post-fall huddle. So you should know, why are people falling in your care? But the other aspect of what's been added to the post-fall huddle, and the only change ever since we launched this over a decade ago, was in 2016, when we did really spend time on focusing on why are people getting injured in your care. And you should know that, colleagues. That should come off at the tip of your tongue. Why are people getting injured in your care? And that's what's going to the Sentinel Alert, the reporting to the Joint Commission. You should know, what is the source of injury. So the source of injury is going to be trauma. So what is causing the trauma when someone actually falls in your care? Is it because they're falling onto unprotected flooring? That's not happening in Lorraine's area because she's got floor mats down. So if you've got people who are hitting things on the way down, if you've got people who are falling onto unprotected flooring, then you're not protecting people from injury, because knowing the cause of injury means that you've got to put some injury reduction strategies in place. Because remember, protecting from injury is separate and distinct from fall prevention. I can fall and keep on getting up, you know, and get up. And I'm not as at risk for injury as people over the age of 85 who are osteoporotic, anticoagulated, maybe post-op. That's the tip of the pyramid. Over 85 at risk for injury because of osteoporosis, anticoagulated, and maybe came in because they had a hip fracture already. They're a post-op. So in protecting from injury, you should know what's the source of injury. So part of what Kristen showed you is that the sentinel alerts, when people are falling and getting injured, is when they're walking. So I can tell you when they're walking, they've gotten up without you and there's no one there. So for someone to get up without you, that means that we need to do a better job of surveillance. We need to do a better job of using position sensing alarms to be able to make sure that we have assisted bed exits and we have assisted chair exits. That should be a goal. Is to, and this can be done in long-term care. You can use not bed alarms for the purpose of fall prevention, but repurpose them for the purpose of making sure you have assisted mobility. You want to assist people to a sitting position. You want to assist people to a standing position. You want to assist people while they're walking. So that means you need to know who needs contact guard versus standby assist. And the other thing that's really important, and I would be interested with about this with Lorraine, because she's focusing on assisted falls as well, is if you're using gait belts. Because the interventions to protect from injury, you got to have floor mats. Floor mats are going to absorb trauma if someone falls from your bed, or can be used in front of their chair. And there's brand new floor mats that are out there called performance mats. And I've presented that to some of the hospitals that I've worked with in the last year that are looking at HD nursing, the Hester Davis program, that has the floor mat that stays down all the time. Once it's down, it stays down, and all four edges are beveled. But floor mats protect from injury. Hip protectors protect from hip fractures. Helmets protect from having head injuries. Low bed positions reduce the amount of trauma that someone sustains because you reduce the amount of distance that someone falls if they roll out of bed. But the low bed position is not the be all and end all position for getting someone to help stand up and transfer. You've got to height adjust the bed height. Because I'm like almost 6 foot tall and my height's different than Debbie's. So you got to know what height to be able to help have that bed at for someone to safely be able to stand up and transfer. So that's another injury reduction strategy. And the newest one that I actually added to my injury reduction interventions is the gait belt. Because there is a study that was published, and it was only one, but it was a randomized controlled trial that was done with that wasn't randomized, but it was, I think it was maybe a cohort study, but it was with critical access hospitals in Nebraska. And what they wanted to see is what would happen with gait belts if someone had an assisted fall. And what they found is that patients who actually had an assisted fall with a gait belt had less serious injury. So I'll just say that again. The patients, residents, patients, but people in critical access hospitals, if they fell with a gait belt on and had an assisted fall, which means we're lowering them to the ground, and that is a fall, Kristen. An assisted fall is a fall, and it's actually a good catch. So I wanted to make sure I mentioned that for you, because if they didn't have someone there with them, it would have been much worse. So it is a fall. So if there's an assisted fall, you should capture that as a good catch. But you need to have a gait belt on them, because with a gait belt, you reduce the severity of injury because it's more of a controlled lowering. However, what we don't know, which is the balancing measure, is what happens with to the staff doing an assisted fall, because we know staff can get injured during that. So that goes for therapists as well as nurses in doing an assisted fall. We really don't know the biomechanics of what happens to staff, even though we're out there trying to promote these assisted falls. So I just went over to you the importance upon admission of not just having fall history, but also injury history, injury risk, making sure that you know that when people fall in your care, you have to know why they're falling, because that should be the key information that's driving all of your strategic planning. Are most of your falls accidental falls? You've got an issue with your environment of care. If most of your falls are anticipated physiological falls, you're not working people up. You're not having individualized care plans. So you've got to be able to really know why are people falling in your care, because those are clinical practice opportunities. And you have to know what's the source of injury. What are the common causes of injury? Now, I just put on an all-day workshop last week with the Louisiana Hospital Association. And I can tell you, I asked my entire audience and asking about protecting people from injury, if any of them knew what was their major source of injury. I mean, this is what we're talking about, because it's injuries that result in loss of function or loss of life. As Kristen said, you cannot prevent all falls, but you got to protect people from injury. And that's what we're not doing a good job about. So I asked everybody, who knows what's your most common cause of injury? Is it falling on unprotected flooring? Is it in the bathrooms? One of the things that you heard from Kristen is falling from bed and falling in the and toileting. The falls that happen in bathrooms are grave, considering the small amount of time that people spend in bathrooms. But when they fall, they hit so many things on the way down before they make it to the floor. Beds. If you don't have floor mats down now, I'm telling you, colleagues, you are not implementing the standard of care for protecting people from injury, because it's the leading injury reduction strategy is to get floor mats down and keep them down at the bedside. So no one raised their hand, and they're not trending the reasons why people are getting injured. So that's something really important to do in analyzing any kind of sentinel event. Now, on the National Falls toolkit, still for the Department of Veterans Affairs, there are resources there for the post-fall huddle. And part of what that includes in the post-fall huddle is an algorithm to help you determine the type of fall that happened based on the root cause, but also preventability. Because quite frankly, colleagues, we do not know what % of our falls are preventable. Did you do everything you possibly could have to have prevented that fall from occurring? Did you do everything you possibly could have to protect your resident or your patient in your setting of care from not getting injured when they fell? Those are the questions that are really imperative, because every one of us has to be intentional in our commitment to protect people in our care. We have to protect them from injury, because it's injuries that result in loss of function or loss of life. And then, of course, being able to prevent falls, knowing that you can't prevent all falls. So, yep, you're going to look at data, but I'm going to tell you, my storyboard is very different than a run chart with data. I can tell you, as an administrator, as a nurse manager in your hospital, that I'm working with you on, every patient who fell in my care, what was the cause of why they fell, because I'm doing a really great job in that post-fall huddle. I can tell you, if someone got injured in my care, what was the source of injury? Because I can tell you, I'm going to make sure that doesn't happen again. Because besides the moral imperative to keep people safe, it is litigious. When people die prematurely because of a fall, when people have head injuries, have hip fractures. So it is our responsibility to actually be able to keep them safe. So my storyboard is what was the cause of the fall or the cause of the injury, the immediate causes. What was the corrective action we're putting in place? How long did it take us to get that implemented, and when did it get resolved? Number one, what was the cause of the fall? What was the cause of the injury? What interventions did we put in place directly aligned to each one of them to prevent it from occurring again? I'm not going to have someone fall again in my care because of the same reason. So what interventions did we put in place? How long did it take us to make it to the care plan, like Kristen was talking about, but not just make it to the care plan, actually get it implemented. So it's date of implementation. I'm going to go look at the environment. I'm going to go talk to my patient. So how long did it take us to get it implemented? And then you got to close the loop. This is systems theory. How long did it take to get it resolved? So if I had an issue in my bathroom that the toilet was too low, or I had insufficient grab bars, I'm going to get that fixed, because I'm not going to have someone fall in that bathroom again because of that. Otherwise, we're going to be using a bedside commode at the bedside, and we're not even going to go into the bathroom. So that's how intentional this has to be. So protecting people from injury is absolutely important. So those are really essentials as I share this. And I do want to say, I have spent a lot of time in the last couple of years spending a real focused attention on the emergency department. So for our hospitals who are on the call, I want to say to you that you should know what % of patients who are coming into your hospital are coming in because of a fall. You should know what % of what's the etiology of the fall, because emergency departments are meant to triage. And how you manage and treat someone who presents to your emergency department that had a stroke and fell is very different than someone who had orthostasis, or someone who who lost their balance getting out of a car. So emergency departments are meant to triage, but if you have someone who comes in because of a fall, you should know the reason for the fall. And if they actually get admitted, they're either broken or they're being worked up, because most people, and I'm sure it's true in Alaska, it's true across the entire country, most people get sent home. Only like 37% in terms of the national data that present to an ER, older adults to an ER actually get admitted, they get sent home. So if you have someone who actually is getting sent home, someone should follow up and make sure that they didn't fall again after they left you, because falls is still a huge reason for recidivism. But if someone actually gets admitted because of a fall, I want to take you to the known faller. We're no longer talking about someone who's at risk for falls. We're talking about someone who actually fell and got admitted. So that's the known faller. Or someone who fell in your care. That's the known faller. That's who I put an armband on, not someone who's high fall risk, but someone who actually fell in your care. Because how you protect that person is going to be very different, of course, than someone who is simply high fall risk. You can't let them fall again in your care. So the ER is and I actually have just submitted an article to the American Nurse today about the emergency room as a very important area. And we have a lot of long-term care residents where they fall and they actually do get admitted into the emergency department. And I'm going to tell you, colleagues, that if you got someone in Lorraine's facility that's using a floor mat at their bedside, when they come into your care, that floor mat should be at their bedside, because patient safety is not setting specific, it is individual specific. So let me say that to you again. Patient safety is not setting specific, it is patient specific. So the safety net has to be the same across settings of care, not just where they're safer in long-term care than they would be if they came into a hospital setting. So I did hear that there was a special request from Bartlett. Bartlett was really wanting help with behavioral health, and I'm happy to help you separately beyond this call if you'd like. I did a 4-month series with a behavioral health program in Oklahoma that I just finished up 2 months ago. But there's a wonderful resource that I already sent to Debbie because I heard of your need. It is from the Minnesota Hospital Association. And I have to tell you, colleagues, the Minnesota Hospital Association has some wonderful resources, and this was their latest that was published in 2021. And it was for behavioral health. And I actually have it on my screen. I don't know if I could share that, but I would say to you, that I love this, and I got to work on this before it actually got released for publication. But it goes into building infrastructure. All of their roadmaps are safe from falls kinds of roadmaps. And the safe part is all about infrastructure and capacity. And the falls part is all about at the point of care, what you need to put in place. This is it. That's right.
There it is.
Yep. So there's infrastructure. And what I actually love, and I use this in behavioral health for the facilities that I was working with, to actually use this as a baseline assessment, to go through every one of the aspects under fundamental. And if you scroll up, excuse me, Debbie, you will see under fundamental, there's a next section that's called advanced. So every aspect of this, see the advanced, every aspect of it, whether it's infrastructure, getting to universal fall precautions, which quite frankly is mostly about creating a safe environment. All of these things in behavioral health, the fundamental ones you should have in place already. These are things that should be in place in behavioral health. The advanced ones are moving you into being a best practice in preventing falls in behavioral health. Now, what's also important, because which is why I wanted to start sharing with you that we're going to reduce accidental types of falls, is because this builds out from universal fall precaution to what do you need to do to create a safe environment and reduce accidental falls? What do you need to do to work people up for their fall risk factors? And that's going to be on another page to go after reducing anticipated physiological falls. But each section, again, has what's fundamental that you should have in place already, and resources to help you get there if you don't have it in place, and then protecting people from injury. So it's going to help you. It's all framed with universal fall precautions, reducing accidental falls, reducing anticipated physiological falls, and protecting people from injury. So you see the accidental falls? So it's a wonderful resource. And when we went through all of this with my colleagues in behavioral health, what we did after that is we prioritized where is there opportunity. for moving closer to getting more of these fundamental things done, but also getting to some of these advanced things that should be in place that would move us to a best practice. So that's what you do for strategic planning. With strategic planning, you always do a baseline assessment of what is in place in your organization compared to what should be in place. And then you look at opportunities for improvement. And you can't take on everything, but you should do at least one thing to create a safe environment. You should do at least one thing to work people up for their fall risk factors. And colleagues, you've got to do something to protect from injury. And then after that, you need to learn, why are people falling in your care? So even those people who aren't in behavioral health, the Minnesota Hospital Association has a Safe from Falls toolkit that's generic, that is built around the same way. And if you have falls that are happening in bathrooms, and I bet you do, the Minnesota Hospital Association also has a wonderful, wonderful resource for creating safe bathrooms. And one of the major issues in our bathrooms is our toilets are too low and we have insufficient grab bars. I can tell you what they are. And you got too much metal, and the grab bars that you have are not working. So I hope that this has been helpful to just get started on what we need to be able to do. And I still want to be able to say to you that you should appreciate that in long-term care, the criteria for the post-fall huddle in long-term care, just like for everybody, is you should know, why are people falling in your care? You know, you've got to know why they're getting injured. And in that regard, that should be the driver for individualized care planning. But it has to be aligned directly to the reason why they fell. So you can't say that someone is weak, because that's not new. You have to know what protective barrier fell through and why the body went down. It's all about the body. It's not about staffing. It's all about things that are proximal to the patient, to the resident, not the things that are so distal that it's not going to make a difference. You need to know why the body went down. It's the same thing even with the sentinel event.
Pat, Gail from Bartlett had a question in the chat.
Oh,
Do you see
great.
that?
Great. Oh, about the grab bars? The grab bars that you have in psychiatry are not grab bars that you can actually have full grasp. They have a protective aspect of it that you can't grasp, but you can't have any ligature risk associated with that. That's all closed material. They can't loop anything.
Not really a bar, it's a grab.
Yeah,
ledge.
you just hold on to it. That's exactly right. But the Minnesota Hospital Association, their grab bars, as they talk about, they don't present it as if it is for behavioral health. It's one that's for all generic bathrooms.
Do others have questions for Dr. Quigley?
Oh, please call me Pat, Debbie.
Pat.
So I hope you're all using floor mats by now. Are you all using floor mats? So I'm sure that there's a yes. If you all put your faces on the Zoom, I could see you. I'll be looking for yes here.
Pat,
There's only a few of us that have our faces that are showing our view.
Pat, maybe you can address Glenda's question. She said she gets resistance on them, that they're a fall risk.
Floor mats? Well, the new floor mat is not. And I'm going to tell you, that's not a reason to not put floor mats down, because protecting the patient from having a head injury or hip fracture outweighs your worry about a staff person tripping. Okay. So the floor mats all have beveled edges. The newest floor mat has beveled edges on all four sides, so you don't have to worry about it being placed down correctly, but it also stays down. So that's the thing, is you've got to, it's the best intervention to be able to absorb trauma when someone falls. And everybody knows that if you fall on padded carpeting, it's a lot less traumatic than falling onto a concrete floor, right? I mean, everybody knows that. You don't need a randomized controlled trial to know that if you fall outside on the concrete on the sidewalk, it's going to be a lot more traumatic than if you fall in your house on padded carpet. For goodness sake, everybody knows that. So that's why you've got to get floor mats down there. And if nurses are telling you that the reason why they're not putting floor mats to protect someone from having a head injury or hip fracture or pelvic fracture or shoulder fracture, then you've got to work them through that, because you've got to protect people from injury. That's the moral imperative. People die from injury. They have loss of function, never function the same way again, breaking a hip. No one ever walks the same again after that. It's not for everybody. And then, you decide on which side of the bed is the safe exit side. So in psychiatry, and I'm from the VA, lots of long-term care psych. In psychiatry, we had many beds that were platform beds and you couldn't move furniture. So then you end up putting a floor mat on both sides of the bed. But and otherwise, as a rehab nurse, I move furniture all the time. And so you create a safe exit side. That's the side of the bed that people get up out of bed on. That's a stronger side towards their unaffected side or their stronger side. And that's the side that you're going to floor mat because people are going to try and get up without you. The other side of the bed becomes the working side of the bed. And that's where you put, if you have to have a table, any kind of other kinds of stuff that's good, IVs in hospitals, it all goes on the working side of the bed. So you can always position a chair to get someone back into bed, going correctly towards their unaffected side. But getting out of bed, that's the side that you want to make sure that if they're going to get up without you, that they're going to be safer. And that's the side of the bed that you floor mat. But I'm telling you, colleagues, I just want to finish about this tripping hazard. It is not a trip hazard. Don't let people tell you that. And I had an occupational health physician that actually dispelled that myth. So the nurses are no more at risk for tripping and getting, having maybe a twisted ankle or something than they are for getting injured with using any kind of new equipment until they're properly trained. So the only trip hazard is walking up onto a floor mat. So pick up your toes. That's the only thing you got to tell people. Pick up your toes. But look at the performance mat.
And you got a question just about cleaning and about the ballpark price that those mats cost, I'm sure.
Well, the cleaning, the performance mat has no stitching on it. So you just follow the vendor product, just to clean it like you would a mat in physical therapy that they use where the patients do their exercises on the mat. So it comes with instructions. There's no stitching on it, so it doesn't absorb any fluid through it. So it's much more infectious control warranted for that. And it's actually approved. The performance mat, you can Google it, performancemat.com, all one word, is actually FDA approved. So it's got class 2 FDA approval that occurred last year. And if you're interested in it, contact them. There's a website there. You can contact them and have them send you a couple. They'll send you a couple and you can give them a try. I mean, try it. But either way, you got to get floor mats down, colleagues. And I know you got, again, a lot of people, especially your older Alaskans, that when they come in, your native Alaskans should be in place at the Native Alaska Hospital in Anchorage. You got to protect people from injury when they come into you can't let them fall and get injured. So how are we doing? Any more?
Any more
I
questions?
can go on forever. You have no idea.
We have until 2, though, folks. You can sign off whenever you like, but come off mute, come on camera. This is our time with Pat. We'd love to hear from you. Any question you have at all.
And your policies, colleagues. So let me just say, I've been so basic with you, but your policies, you should have universal fall precautions. Of course you should, but you shouldn't put non-skid socks on someone who can't feel their feet. So even universal fall precautions have to be individualized. You've got to do that. So yeah, you're going to go have universal fall precautions. Then you want to have reducing preventable falls. Don't go after preventing falls because you can't prevent them all. So you want to reduce accidental falls related to a safe environment. So you got to do something to do environmental evaluation. And then you've got to be able to protect people from anticipated physiological falls. So you have to make sure you check in older people for postural hypotension before you start walking them, for goodness sake, because it's a risk factor. And everybody has to do it right. Lying, standing, no lying to sitting. So you got to work on anticipated physiological fall in your policy. Then you got to protect people from injury. Those are the 4 key components. But the next step is then you have to go to specific populations. Because how you prevent people from falling that are new maternity patients, the first new mother that just delivered, that new mother is going to overestimate her abilities. She's not going to wait for help. So you have to rely on your specialty knowledge to go after specific populations. So how you protect a new mother from falling is going to be different than an experienced mother. You got to, and there's risk assessment. HD nursing does that for the maternity population. How you protect people who have had a hip fracture surgery is going to be different than someone with Parkinson's. So that's when you start going after fall prevention using your clinical expertise for specific populations. You all know that a left brain CVA is different than a right brain CVA. A left brain CVA has aphasia. How you protect them from falling is different than a right brain CVA who's impulsive and can talk to you and listen to you. So that's the next part of your fall prevention program, is going after populations, but you decide who you're going after. Me, I want to protect my 85-year-olds because my 85-year-old is right here at the tip of my pyramid because they die if they fall in your care. Doesn't matter what their score is. Doesn't matter in your long-term care facility. If they fall, they're more likely to die than anybody else. So I protect my 85-year-olds. That's who I embrace. Some people embrace babies. We're going to, no one would ever tolerate the death rate in babies and infants and toddlers that they do in old people. So that's why I'm going after the 85-year-olds. And then in addition, after that, then you have to go after education. You have to make sure that when you're educating people, you're not talking to them, you're talking with them. It's with me and about me. And you have to make sure they learn from you. For people who are cognitively alert. For people who are cognitively alert, they should be able to tell you back. They should be able to show you back. You should be able to teach them so well that they can tell you 100% reliably why they're at risk for falling. Why they're at risk for injury if they fall in your care. They should be able to tell you back what happens if they get up without you when you told them that they need to call for help. That's how well you need to be able to teach people. So that's patient education. And then, of course, there's people with dementia, because people are not everyone's cognitively impaired. So that's all building your fall prevention program, because for people with cognitive impairment, you got to keep them safe, keep them safe, keep them safe. You got to anticipate their needs. You got to work with family members to know what their fall risk factors are. You got to keep them safe, keep them safe. And that's who you do surveillance. So those are the people you're going to be using telesitter technology for. You're going to use the position sensing alarms for, and you don't use bed alarms or anything like that because someone's simply high fall risk. You use clinical criteria, cognitive status and mobility status. So everything should rely on your clinical expertise, because if you go way back to 2010, one of the most cited pieces of literature, Dr. David Oliver on preventing falls in hospitals, it's a resource for every publication that's come out after that, has said to all of the nurses who are on this call that there's no better prediction of a patient falling than the clinical nursing expertise. So rely on your judgment, rely on your expertise. You know who's vulnerable, you know who is at risk, but you have to talk about why they're at risk, not just say that someone's high fall risk and put an armband on it, because it's not going to get it. So I know we got a few more minutes, because honestly, I can go on forever.
We can listen to you forever.
Yeah.
Oh, thanks.
Anyone have any other questions? For Dr.
And try doing fall rounds. People do discharge planning rounds. Try doing fall rounds. Go over the care plan with your patients and their families and see how their fall prevention program's going. See what they're learning. See what their concerns are, because I can tell you their concerns are not the same as yours. Patients' perceptions about the risks of falling are not the same as yours. We get held to performance measures, as you heard from Kristen. We get held to now fiscal reimbursement or not. If someone gets injured in your care, you don't get paid for that. So, patients don't have the same perception about the risk of falling that we do. And it's even very true in terms of gender, differences in gender perspectives, because there are people, and even though it's mostly men, that they're not going to wait for you to call for help. They don't want to call you for help. My population is the veteran population. I can tell you, they've borne the battle for us and others to be free. They jumped out of planes into the battlefield, and they're not going to call you for help, and they sure don't want you to stay with them in the bathroom. So, you got to get over something and find different ways to have conversations with people to help them understand who's more vulnerable than others, that you really need to be with them. You have to be with them because they're so at risk that they don't realize how at risk they are. And you want to do everything you can to be able to protect them. Appreciating still that most of the falls happen at home, then they fall in the community, and then in your care. So falls still in hospitals are rare, but they are still the leading sentinel alert and a sentinel event in the Joint Commission.
Thank you so much.
You're welcome.
So I did put a link to a survey if you guys that are still on the call want to complete that. That will help us with these offerings. And I did want to say that we've been doing these every month, but we're going to switch to every other month. So the next one will be in February. And definitely reach out to Debbie and I if you are interested in working more with Pat Quigley on with your falls and your
Yeah,
facility.
and I'd love to
Okay.
know if this was helpful to you. For those of you who I can see your face, was this helpful to you? Okay.
You can do a little thumbs up in the reactions.
Oh, that's a good thing to do.
Yeah, give a little thumbs up if.
Oh, that's great. I don't even know if I know how to do that. How do you do that?
Reactions down at the
Oh,
bottom.
very cool. Well, it's because of Debbie that I'm here. So, Debbie, I can't thank you enough. You made my holiday season special, letting me be home in Alaska with you. And
Great.
I'm glad to be able to invite you into my kitchen in Tampa Bay, to my home.
Well, we want your weather right now because
Oh,
Alaska's
I send you,
not such great weather
absolutely.
right now, but.
Yeah, send you sunshine and warmth,
Well,
always.
thanks so much, Pat. Have a
Anytime,
great
anytime.
holiday, and I'm sure we'll be in touch in the new year. And Kristen, anything else or
No,
signing
I
off?
can't think of anything else. Thank you
Okay.
everyone for attending, and we'll have the recording available soon for people if they need it.
Yeah,
Happy
we'll send the
holidays,
report.
everybody, and I wish you good health and a hopeful new year.
You too, Pat. Thank you so much. Great to see you.
You too. Love you guys.
Bye.
Bye, everybody. Thanks for all you do. Bye, Glenda. Glad to see you. Thank you, Glenda.
Bye. You're welcome. Thanks for. Sorry I was late.
Thank you for letting us see your face, Glenda. Not everybody does that. You're just
Yeah.
delightful.
Not many people came on camera, so that was nice.
I know.
Well, we got to keep ourselves accountable. I don't want to fall asleep. Not that.
No, I know you wouldn't. Thank you, colleagues.
Okay.
Thank you so much. Bye, Kristen. Nice to meet you.
Good to
Thanks
meet
for
you.
your
Bye.
leadership. Bye, Deb.
Bye.